So, welcome to part D, I believe, or part 4 of Chapter 1. So far we've focused on the first two parts, which was spontaneous breathing, both the initially the static components of the pleural pressure followed by the dynamic components of the pleural pressure. And then we looked at work of breathing in the spontaneously breathing patient in the previous portion, and now we're moving to mechanical ventilation, which is obviously very prevalent in the intensive care unit. The advent of the mechanical ventilator essentially was the initiation of the modern day ICU. So mechanical ventilation, it's critical to understand the physiology behind mechanical ventilation, and I think that the Campbell diagram can be used again as a nice way to illustrate the physiology of mechanical ventilation, how it can be modified, which you can briefly review in my introductory lectures. So mechanical ventilation, let's talk about pressure. As we've been talking about like crazy, pressure is very important. Unlike spontaneous breathing, where the inspiratory and expiratory muscles are performing the work of breathing by altering the pleural pressure, so pleural pressure essentially is the independent variable in spontaneous respiration. The work of breathing during mechanical ventilation is maintained by the ventilator, and this occurs by applying a distending volume or pressure in the proximal trachea. Now, this entire box, which is an absurdly long sentence, poor English on my part, I'm sorry. This is under the assumption that the patient who's being mechanically ventilated is completely passive with the ventilator. So this patient is heavily sedated and potentially paralyzed. So there are no active inspiratory efforts. When the patient starts actively inspiring by him or herself, the picture becomes very muddy, and it's essentially impossible to predict the degree of change in intrathoracic pressure during mechanical ventilation in those patients just at the bedside. There's some markers that you can use, for example, changes in the wedge pressure with an inspiratory effort. You could drop an esophageal pressure probe and use that as a surrogate for change in pleural pressure. But again, it becomes very difficult to predict in those patients. So this is predicated upon the assumption that the patient is completely passive with the mechanical ventilator, which, as many of you know, is kind of uncommon in the ICU. So, also important is that the pressure monitored in the ICU, and by ICU I mean by the ventilator in the ICU, the pressure that causes all of those alarms and bells to ring through all hours of the night, which still haunt me when I'm asleep. That pressure that's being monitored is not the pleural pressure. Repeat, not the pleural pressure, unless estimated via an esophageal balloon, as I just mentioned. But rather, this is the proximal tracheal pressure, and there can be a huge difference between, as many of you are aware who are familiar with ventilators, there can be a massive difference between the proximal tracheal pressure and the pleural pressure. And the proximal tracheal pressure is not the hemodynamically important pressure per se. When mechanically ventilating the passive patient, the hemodynamically relevant pressure, that is the pleural pressure or the intrathoracic pressure, is kind of a physiological bystander. It is no longer the independent variable as it is in spontaneous ventilation, but it is the dependent variable. I've got a lot of words here. So when ventilating the passive patient, the lung and chest wall are moved as a unit, and you can sort of picture the mechanical ventilator applying this force to the proximal trachea, and then that's distending the lungs, and then which are distending the chest wall outwards. So consequently, the graphical analysis is typically done in terms of the compliance of the respiratory system. And as I've mentioned multiple times before, when I say respiratory system in my talks, I'm referring to the combined lungs and chest wall together. But the Campbell diagram can be used to illustrate this physiology. Okay, here's a picture. So back to the Campbell diagram, and we're going to initially talk about the static pressure of mechanical ventilation. So recall, under conditions of no airflow, that at any given thoracic volume, it is the lateral distance between the passive chest wall elastance curve and the passive pulmonary elastance curve. It's this lateral distance here, pressures on the x-axis here, that determines how much the muscles of inspiration must work, or what the pressure change must be to affect that volume that you want to obtain. Consequently, it's the amount of pressure that the ventilator must also apply to obtain that same volume. So this modified Campbell diagram, for these curves here, the x-axis is kind of pleural pressure. But for the respiratory system curve that you're about to see, the x-axis is the proximal airway pressure. So this is a very different pressure. This is the pressure that you're measuring off of the ventilator. So it's critical to understand that. And this is what I just said. So you can kind of graph this. If this is the lateral distance, the pressure that must be applied by the ventilator to obtain this volume, remember volume is on the y-axis here, well then you can graph it out here. And so this is the amount of proximal airway pressure that must be applied to obtain this volume. And then you can graph out more volumes and you can get this curve, which is the static pressure curve, or the elastance curve of the respiratory system. Again, the lungs and the chest wall together. And for those of you who are familiar with ICU parlance, these are just serial static pressures, or serial plateau pressures. So if you were to do this experiment at the bedside, you could give a small volume to the patient who's passive, and then measure a plateau pressure. And then on the next breath, give a larger volume, and then measure the plateau pressure on that. And then on the next breath, give a larger volume, measure the plateau. So this is just a sequence of plateau pressures which defines the compliance curve of the respiratory system. And again, here's the pressure waveform. We've got your peak pressure here on the left, and this is the pressure. Again, this is what you see on the ventilator interface. Airway pressure on the y-axis. Time is on the x-axis. It's key to understand that this is time, because when you make the ventilator a constant inspiratory flow, and those of you who are familiar with ventilators will understand the difference between a constant inspiratory flow and a decelerating flow pattern. Decelerating flow pattern tends to be a little bit more physiological, a little bit more tolerated by the patient. But what's in terms of the square wave or the constant flow, what's uncomfortable for the patient is a little bit more comfortable for the physiologist, because when you make flow constant, then you're taking a changing variable out of the equation. You're making it constant, which is helpful to analyze these pressure-time differences. When flow is constant, that means volume and time become linear analogs. So in a sense, this then becomes a pressure-volume graphical analysis. The static pressure, or plateau pressure, is the pressure maintained at the proximal trachea after a cessation of airflow, so that you give the patient a breath, inspiration, expiration, inspiration, hold, you push a button on the ventilator and it stops flow at the end of inspiration here, and then it plateaus out. And then this pressure is the plateau pressure, and this is the pressure required at the proximal trachea to maintain a given thoracic volume at no airflow. And it can be thought of really as your alveolar pressure really at end inspiration, because if you've ceased flow, then you can think of this as being a continuous static column of gas between the endotracheal tube at the proximal trachea and the alveolus. And then going back to the bag and tube model of the lung, which I introduced in the first part of this chapter, the static pressure is the pressure that's required to maintain the thoracic volume in the absence of airflow, as I mentioned. And then you can, in this pressure time graphic, you can generate a slope here, and I'll talk about this in a few more slides. But really, and I think you'll understand why in the later slide, the slope of zero airflow to the static pressure, this approximates the compliance of the respiratory system. And this is the compliance equation. And as you know, compliance is change in volume over change in pressure. So here the change in volume is the change in I've written lung volume, but kind of technically it's change in thoracic volume, and that is the change in pressure is the static pressure, or really I should have written plateau pressure minus the end expiratory pressure. And that will give you the compliance of the respiratory system, again, the lung and the chest wall together. So the plateau pressure, which is a measure of the compliance of the respiratory system, determines thoracic volume. It does not determine the pleural pressure per se. How much of the plateau pressure, again this is the pressure at end as inspiration, is distributed to the pleural space depends on the relative compliances of the lung and chest wall. So if you have a given plateau pressure or a given static pressure of the respiratory system, how much of that really alveolar pressure at end inspiration is partitioned to the pleural space is dependent upon the relative compliances of the lung and chest wall. In general, if the lung is much less compliant than the chest wall, then less of the plateau pressure, less of the alveolar pressure is partitioned into the pleural space. And in that situation, you have a higher transpulmonary pressure, which is the alveolar pressure less the pleural pressure. Conversely, if the chest wall is much less compliant than the lungs, then a larger portion of the plateau pressure or alveolar is partitioned into the pleural space, and in that situation you'd have a lower transpulmonary pressure, which is the, again, alveolar pressure, less the pleural pressure. So the change in the pleural pressure can be estimated, and again, this really isn't a quantitative equation. This is much more qualitative because it's very difficult, if not impossible, to get accurate measurements of these things clinically. Compliance of the lung is difficult to obtain clinically. I've actually never even seen it done, but it required an esophageal pressure balloon and get an estimate of the pleural pressure, and it just isn't done. This isn't so much for quantitative purposes. It's more just to understand the physiology behind it. And this change in pleural pressure, it's this fraction of the plateau pressure based on the relative compliances of the lung and chest wall. This is, again, the plateau pressure is an end inspiratory pressure. The same equation can be applied to end expiratory pressure. And instead of P plat here, it would actually be P peep, which is your end expiratory pressure. So again, this is an inspiratory maneuver here. It's the plateau pressure. So you start with the plateau pressure. You consider in your mind the ratio of the lung compliance to the chest wall compliance. And then you can kind of have three general categories. If the ratio is low, lung compliance is much lower than chest wall compliance. So you think of a thin patient with ARDS would be kind of a prototypical example. So maybe a thin cachectic COPD patient who's aspirated and developed a terrible ARDS. Well, this ratio is going to be very low. So much less of this end inspiratory plateau pressure is going to be distributed to the pleural space, or to the pleural pressure. And the same can be said for the application of PEEP for this patient. While this refers to an end inspiratory pressure, the plateau, the same can be said for an end expiratory pressure. If it's roughly equal, as the lung and chest wall compliances are roughly equal in health, then roughly 50% of the plateau pressure at end inspiration or PEEP at end expiration will go to the pleural space. And if it's very high, and you think of, in this patient, the obese kyphoscoliotic patient with COPD, so this patient has a high pulmonary compliance from the COPD, and then very low chest wall compliance, which makes the ratio high because they're obese and they've got kyphoscoliosis or massive ascites or you name it. Then more of the plateau pressure at end inspiration or more of the PEEP at end expiration will go to the pleural space. And again, these are very, very rough, rudimentary, qualitative assessments When Pinsky and colleagues looked at applying this clinically, the ability to predict exactly how much of the peak, excuse me, not peak, how much of the plateau or PEEP and expiratory pressure actually distributed to the pleural space, and in particular the pericardial space, it was very difficult to predict. And that probably has to do with the way that the lungs and the mediastinum expand towards the heart during an inspiratory breath, and so the pressure changes there may actually be higher than one would predict because of this compressive effects of the lungs. And there's other factors, including the pericardium itself and the volume of the heart. So this is really more to appreciate the underlying principles of physiology more than anything else. And then a little bit more about the plateau pressure. The concepts that I just talked about can be graphically illustrated by returning to the Campbell diagram. The pulmonary elastance curve provides the relationship of pleural pressure to lung volume when breathing spontaneously, whereas the chest wall elastance curve approximates the relationship of pleural pressure to lung volume when mechanically ventilated. And the elastance of the respiratory system, or compliance of the respiratory system, they're just inverse of each other, provides the relationship of the static proximal airway pressure, the plateau pressure, to lung volume when mechanically ventilated. That's the plateau pressure, pleural pressure. Chest wall's pleural pressure, respiratory system is plateau pressure. And I think you'll see that in just a moment. So this is what we've previously talked about in terms of the lung and chest wall elastance curves and how you derive the elastance curve of the respiratory system from the two. And this would be if you did an end inspiratory hold at this volume, you would get this plateau pressure, this proximal airway pressure, which is kind of a surrogate of your alveolar pressure. But this would be actually the approximate pleural pressure in this patient. And the reason this is because, again, the mechanical ventilator is applying a force to the proximal trachea, and then the lungs are being expanded, and they're being expanded into the chest wall. So the chest wall is kind of that last barrier of resistance. Maybe resistance is a bad word, but it's the last barrier to expansion after a force is applied to the proximal trachea. So the pleural pressure tends to track the chest wall elastance curve in the passive. Again, this patient is not making any inspiratory efforts. So let's look at why that intuitively makes sense, or graphically makes sense. So imagine a drop in the pulmonary elastance, you name it, ARDS, really bad alveolar edema. The pulmonary elastance curve shifts down and to the left. So what does that do to the distance between the passive pulmonary and chest wall elastance curves? Well, it's increased the distance. And as we know, this will decrease the compliance of the respiratory system. So now you have a plateau pressure of, say, this. So this is your plateau pressure or your alveolar pressure. This is your pleural pressure, and the ratio of how much of the alveolar pressure is distributed, how much of this decreased compliant respiratory system, how much of that alveolar pressure or plateau pressure is distributed to the pleural space, to the pleural pressure, is diminished because most of the drop in respiratory system is being driven by the poorly compliant lungs. So the pleural space sees less of this pressure, and you can sort of think if you were trying to ventilate a balloon that is being surrounded by your hands. The balloon is the lung and your hands are the chest wall. Well, in this situation, the compliance is impaired of the balloon. So if you, instead of a balloon, if you imagine kind of a balloon made out of Kevlar and you tried to blow into that, well, the pressure between the outside of the Kevlar balloon and your hands is not going to increase all that much because the Kevlar balloon is not going to expand as much and compress the chest wall and elevate the pleural pressure. So the pleural pressure is relatively spared when the pulmonary compliance is reduced. I hope that example you can sort of picture in your mind. So again, just to reiterate, the plateau pressure is increased because of the poorly compliant respiratory system, but the pleural pressure is relatively spared, and that's because the primary problem here is a drop in the pulmonary compliance, not the chest wall compliance. Okay, so the other option is now you going from the Kevlar balloon surrounded by your hands, now you're going to inflate a normal balloon, but you're going to press your hands around it really hard. So that represents, your hands again represent the chest wall, and now you have poorly compliant chest wall. Well, as you blow into that balloon that you're gripping in your hands, the pressure in the space between the balloon and your hands is actually going to go up much greater, and that's because it's the chest wall compliance that's driving the pressure there. So here's the drop in the chest wall compliance curve. It shifts down and to the right, and just like before, the lateral distance is increased, so the compliance of the respiratory system, the lungs and chest wall together, is also decreased. But while the plateau pressure is increased, the pleural pressure has increased. The transpulmonary pressure, which is really the lateral distance between these two, is also decreased relative to the patient who had the poor lung compliance. So when the drop in thoracic compliance, that is the compliance of the respiratory system, is due to a drop, that's maybe bad terminology here. Instead of saying when the drop in thoracic compliance, I should probably say when the drop in respiratory system compliance is due to a drop in the chest wall compliance out of proportion to the lung. Much more of that proximal airway pressure, that plateau pressure, that end expiratory pressure will be distributed to the pleural space, and intrathoracic pressure will rise. So that's it for static pressure and the mechanically ventilated patient. So let's now move on to dynamic pressure in the mechanically ventilated patient. So while the plateau pressure and the compliance of the respiratory system determine thoracic volume, there's also the dynamic component that must be applied by the ventilator. And much like spontaneous breathing, this dynamic pressure accounts for overcoming the inertia to gas flow. This too is seen in the proximal airway pressure. So if you've ever had a mechanically ventilated patient with really bad asthma, you'll know that their proximal airway pressures will go way up. And this can be analyzed graphically on the modified Campbell diagram as well. So this is the respiratory system elastance curve that we just talked about, not the pleural pressure. This is the proximal airway pressure measured by the ventilator. But the addition of gas flow and airways resistance requires this additional pressure here. And again, the x-axis here is airway pressure, not pleural pressure. This is what the ventilator is recording. So to overcome the airways resistance, you add this right shift, or this rightward curve. And you can zoom in on this portion as we did on the patient who was spontaneously breathing, and you can see here that the amount of airway pressure, which is to the right of the y-axis here, this is the y-axis zoomed in, the amount of airway pressure has some of it, during an inspiratory breath, some of that airway pressure is dedicated to maintaining volume, and that's defined by the respiratory system elastance curve, and some of that pressure at the proximal trachea is dedicated to overcoming the airways resistance, and that's determined by the lateral distance to the right of the respiratory system elastance curve. And again, it's all color-coded. Blue, again, is a static property, and red is a dynamic property. Back to the bag and tube, with the bag being the blue, volume, static pressure, and the red being the tube, which is resistance or dynamic pressure. Okay, and then just back to the waveform that you see on the ventilator. We talked a little bit about this a few slides ago. The peak proximal airway pressure is the summation. Again, it's a summation of both the static and dynamic components of airway pressure. Therefore, the lateral, or again, this is pressure, so the distance between these two when you do an end inspiratory hold, the distance between these two, between the peak and the plateau, is actually a measure of airways resistance. And again, I can't stress this enough, this analysis between peak and plateau can only be done in a constant inspiratory flow, the square wave flow. And if you have it, because if you have a decelerating flow pattern, you can imagine that this peak pressure will begin to decelerate. The dynamic component of pressure will begin to decelerate at end inspiration, not because of any change in airways resistance, but simply because the flow is decreasing. So there has to be a constant inspiratory flow throughout the inspiratory breath to make this analysis here. See, I see this done incorrectly all the time. So, as I mentioned, the degree of separation here, again, this red is dynamic. This defines the dynamic component of airway pressure at the proximal trachea. Again, highlighted when the ventilator is set at constant flow. I can't say it enough. That's what can help pictorially represent the dynamic component of airway pressure. And there's an equation that can be used to calculate the actual airway pressure, and it makes sense. It's the peak pressure less the static pressure, so da-da minus da-da over the flow, and it's a constant airflow. And then going back here, now you can kind of begin to appreciate that when it's a constant flow and time and volume are linear analogs, so this essentially becomes like a pressure volume curve, that you have this component above this line is dedicated to the red, the dynamic component, and then this component below the line is dedicated to the static, or the blue. And if you were to sort of rearrange this graph and put time or volume on the y-axis and pressure on the x-axis, you can picture what that might look like. And we'll get to that in a bit. So the proximal airway pressure is the summation of the static and dynamic. So this is the static component, so the peak airway pressure. Static is the tidal volume over the compliance, plus the dynamic, which is the airflow multiplied by the airway's resistance. And going back to the bag and tube model again, just for repetition, the peak pressure is the amount of pressure that is achieved in the proximal airway in order to maintain a given volume and a given flow. And the peak pressure on the ventilator is therefore akin to the pleural pressure during spontaneous breathing. The key difference is that the pleural pressure during mechanical ventilation is largely determined by the static components of the lung and chest wall and little affected by the dynamic component of gas flow. And you can sort of think that in a patient with bad asthma or bad obstructive airways disease, that high peak pressure, that high proximal airway pressure, the resistance is actually in a way kind of protecting the alveolus and the pleural space. So a lot of that high airway pressure you see in high airways resistance is not being transmitted to the pleural space. So graphical representation of the pleural and peak pressures. The compliance curve for the chest wall is the static pleural pressure. As illustrated here, we've seen this already. The chest wall, static pleural pressure, and the elastance of the respiratory system is your plateau pressure. But if you wanted to graphically represent a large increase in airways resistance, you would have a greater shift to the right of the dynamic portion of this curve. So this patient compared to this patient has lower airways resistance, this patient has much higher airways resistance. And so that would be translated to a much higher peak proximal airway pressure measured on the ventilator. So this distinction here is critical, that on the ventilator you are measuring the peak pressure, the plateau pressure at an end inspiratory hold, and these can be very different from the pleural pressure, which is the hemodynamically significant pressure. Pressure waveform. In summation, the pressure waveform tracks the peak pressure through a breath. The peak pressure varies by this following equation we just talked about. in a volume-targeted mode of ventilation with a constant flow delivery, then the only two variables that can change the peak pressure are the respiratory system compliance and the airways resistance. Note that the respiratory system compliance and the airways resistance may vary between breaths and within a breath, and that end inspiratory hold maneuvers, that is obtaining a plateau pressure, can help tease out the difference between changes in compliance and resistance. However, the main determinant of pleural pressure, and consequently the effects on the circulatory system, is the static pressure. So that would be a plateau pressure at end inspiration, or the end expiratory pressure, whatever that may be. It's often set on the ventilator, known as the PEEP. So from that pressure waveform, we can also have a very brief discussion on work of breathing on the mechanical ventilator. We talked about work of breathing in the spontaneously breathing patient in part C of this chapter. But you can also derive this information from critically analyzing the pressure time waveform in a volume-targeted mode of ventilation with a constant flow. Again, it's got to be the square wave. In that situation, then pressure and volume co-vary at a constant flow. And remember, as we saw in part C of this talk, that it is really the area under the pressure-volume curve, or the integral of that curve, that defines work. So when this becomes pressure-volume, then the areas of this curve actually are graphical representations of work. So if you were to parse this out into the elastic or static and resistive work of breathing, you can visualize it here. So this is the resistive, and this is the elastic, and again it's color-coded, red and blue. Now, as I mentioned in a few slides ago, when time and volume are linearly related, then you can sort of think of this as a pressure-volume graph. And remember, the Campbell diagram is volume on the y-axis and pressure on the x-axis. So if you sort of flipped this curve, well, what do you see? You actually see this. This is that zoom-in portion on the modified Campbell diagram, where now volume is on the y-axis and pressure is on the x-axis. It's not depicted here. But this blue portion of this breath is actually the elastic work of breathing, and the red portion of this graph is actually the resistive work of breathing. And the line between the two, this line, actually represents the compliance or elastance of the respiratory system. Pretty cool for some of you. Others of you are sleeping right now. So, as I mentioned in previous slides, mechanically ventilated patients with spontaneous efforts, which is more the norm in the ICU, I think, makes difficult good estimation of the intrathoracic pressure, unfortunately, and that's because the characteristics of the chest wall is actively changing throughout each breath, and the patient's muscles of inspiration and expiration are being recruited. Then you really are kind of flying blind in terms of estimating what the true intrathoracic pressure is, because there's one force driving the intrathoracic pressure down. That's the inspiratory efforts of the patient, or expiratory efforts of the patient would drive it up, and then you've got the mechanical ventilator, which is tending to drive intrathoracic pressure up during inspiration and then down during expiration. So it really becomes impossible. So it can be commonplace for intrathoracic pressure or pleural pressure to be very negative even when the patient is mechanically ventilated. And I think this concept is lost on a lot of house staff. It's just assumed that if the patient is tubed and mechanically ventilated, then intrathoracic pressure is always positive, and that's not necessarily the case, and this can even vary widely in any given inspiratory-expiratory cycle. This is especially true, obviously, when pressure support modes are used, or especially things like CPAP or BiPAP, non-invasive positive pressure, which obviously requires the patient be actively breathing because they do not have a protected airway on non-invasive positive pressure. So essentially, if they can't actively breathe, it's a contraindication to non-invasive positive pressure. So that's the physiology that's going on there. And you can kind of analyze the effect of adding pressure to support to a patient who's spontaneously breathing. So you could sort of think of this as like adding BiPAP or CPAP, or even tubing a patient and placing them on pressure support where they're driving their own inspiratory and expiratory needs. So if you imagine this patient who's got a fairly high resistive work of breathing and a fairly high elastic work of breathing, so as I mentioned, this patient's got reduced lung and chest wall compliance and has increased airways resistance, so these elastic loads are high. And then the application of pressure support ventilation improves the effective compliances of the lung and the chest wall, unloads the muscles of respiration, improves airflow resistance, and mitigates extremes of pleural pressure. So this patient may have a very negative pressure on inspiration, and I don't have it depicted here, but on expiration they may be forcing air out and have a very high expiratory intrathoracic pressure. And the application of pressure support really changes that and reduces the work of breathing, both the resistive and the elastic work of breathing. And this can be graphed. Some ventilators have the ability to make these measurements, but you have to drop an esophageal pressure probe on these patients. So this computer can simultaneously analyze esophageal pressure as a surrogate for pleural pressure, as well as the proximal tracheal pressure as the airway pressure. And these work of breathing graphs can be created, but it hasn't really translated to being a clinically useful tool. So that's it for part D, or part 4 of Chapter 1, all about mechanical ventilation in the Campbell diagram. And after this we'll turn to the final section of Chapter 1. It's a fairly brief discussion on auto PEEP, or auto positive end expiratory pressure. Thanks.